Good morning, everyone, and welcome to our Risk Management Grand Round session. I'm Tracy McCallan, Associate Chief Quality Officer for Education, and thank you all for joining us early this morning. We have a full agenda, so our first hour, we will be having a number of our quality and safety leaders presenting. And we'll be talking about some common elements to safety events. We will be discussing some of the sepsis work here at Rainbow, as well as the IPSO Collaborative and some improvement work that we've been doing, as well as escalation of care. In the second hour, I am pleased to welcome Lynn Hardacre, Vice President and Deputy General Counsel, along with Sarah Stover, Associate General Counsel from our legal team, who will be doing an hour on a risk event and resolution policy, disclosure and documentation of events, and navigating challenging discharges for pediatric behavioral health patients. Just a reminder that this is quality protected and confidential information we will be discussing today. In order to receive your credits for our risk management CME, please sign in person if you are here in the amphitheater. If you are on Zoom, please change your Zoom name to your full name or enter your name in the chat. With that, I will turn it over to our Director of Quality and Safety, Joyce Deptola.
Tracy. Good morning, everybody, and welcome to those on via Zoom. Nice to have all of you here today. So when we look at the first hour, I think this is all going to tie together pretty nicely for you. We're part of a patient safety organization, or a PSO, and we'll talk about what that is here in the next slide. But we have some shared learnings from the children's hospitals that evaluate their safety events, especially diving into serious safety events. And what we see through those teams, it's about 50 of our hospitals across the children's hospital landscape. There are three consistent themes. These are historical themes. They're also current themes. They have not changed much over the past 5 years or so, but three common contributing factors bubble up into those systems issues, diagnostic opportunities being one, care coordination being another, and then finally communication. So I'm going to go into a little bit more detail into those things, but we thought perhaps it would be best if we introduce you to what the PSO is. As Rainbow is a founding standing member of the PSO, you all have an opportunity to participate through this, and as we do as an organization. So a PSO in general is a federally recognized organization that works with healthcare teams, organizations to improve patient safety and quality. Their purpose is to collect and analyze data that's voluntarily submitted or shared by those organizations with the goal of reducing risk and patient safety events. We have our own pediatric PSO, patient safety organization, called Child Health PSO. It stems from the Children's Hospital Organization or Association, and it is the only federally registered PSO dedicated to children's hospitals by the Agency of Healthcare for Research and Quality, or AHRQ. That allows us federal privileges and protections for confidential event reporting under the 2008 Safety and Quality Improvement Act. Here in Ohio, we have a little bit more liberal rules around patient safety work product and how we share those things. In many states, there are really specific and stringent rules around how patient safety work product is shared, even in a discussion like we're going to have later today around one of our sepsis cases. But with that, we can share learnings from those pediatric partners in the PSO in a protected environment. So how does that look? What does that feel like? Kate, Dave, Ira, and I have been active members in this work over the past several years, but there are weekly PSO huddles. We're one of 40 hospitals that gets on these huddles each week. It's a round robin report out from those 40 hospitals or those that are on the call. And really the purpose of that is to escalate concerns or notifications of an event that we are trying to understand, and then requests for help. So many of our requests are things like, after a learning review, when we have a safety event, we might say, gosh, we need a guideline for this, or what do other children's hospitals do with this situation? And we put out there on these huddles, what are people doing around this situation? Does anyone have a policy or a guideline or an evidence-based practice around these things? And then we have nice sharing across those hospitals, so we don't have to recreate the wheel on things. We ask for help and we respond to asks for help, and we get measured in how well we do that in our participation measurement. Then there are monthly PSO safe tables. There's one today that I'll be facilitating. It's a hospital that's going to share a safety event from their organization, and they'll talk about what they learned from that, what kind of those systems issues that were identified, and then their action plans to that event. So for that, it's really excellent because we can understand from other people's learnings and we don't have to recreate the wheel. And it does provide us some nice proactive insights into things that we might not have thought could happen in our organization. And that also drives some safety alerts when the PSO sees some consistent themes bubbling up. I'll tell you, there's lots of things around NG tube placements into lungs and things like that. There are definitely consistent themes that pop up. They will send out some action alerts for hospitals or safety alerts that we can bring to our safety council in a protected venue and talk about the risk to those things in our own hospital. In terms of what we get from that membership in Rainbow, it's really that proactive approach to learning, and it helps us identify those latent safety risks before they lead to harm for one of our patients. So lots of benefits there. I would say it's one of those things that we probably underutilize, but our goals is to be better stewards of this and to better learn from the learnings of our peers. I'm going to hand it off to Ira because we're going to continue to talk about how then we solve for those diagnostic opportunities.
Great. Thanks, Joyce. For those of you who don't know me, I'm Ira Chaifetz. I'm the Associate Chief Quality Officer for Patient Safety and the Chief for Cardiac Critical Care. This next section, we're going to talk about teamwork. Everything we do in life is somehow related to a team. But that is especially true when it comes to patient safety. So start with just 3 key concepts. Situation monitoring. If you think about trees and forests, these are the trees. That individual patient, that individual situation. Do we have all the data that we need to assess what's going on in that specific entity, whatever that happened to be? Take a step back now to the trees, from the trees to the forests. Situational awareness. Are you aware of what's going on elsewhere within your clinic, your ICU, the emergency department, wherever you are? You're focused on one patient, but what's going on down the hall, next door? What are your team members doing? What are their priorities? Trying to see the big picture while you're also focusing on the trees. And then the last is shared mental model. Are you and your teammates thinking of the same situation similarly? Are you aligned in your thought process and your goals? If you are, great. If you're not, that might be okay as long as you realize that you have a different shared mental model. And then how do you discuss and how do you work together to come to that same shared vision? And we'll come back to those last 2 entities, which are quite important at the end of this section. We start from the bigger concept of a team, high-performing teams. Teams that perform well hold shared mental models. Kind of makes sense from what I just said. Have clear roles and responsibilities. What is your role? How does that relate to the roles and responsibilities of your team members? So my role is in attending in the ICU, obviously to see the big picture, manage the situation, but I can't do what I do if the nurses, respiratory therapists, nurse practitioners, everyone else aren't doing what they do and doing it well. And how do those roles and responsibilities relate to each other? Have a clear, valued, and shared vision. Optimize resources, and resources are not only physical resources, they're people resources as well. How do you allocate limited staff in a busy clinic, busy ICU, busy program to have the optimal outcome, not only for that day, that week, and that program or unit from a big picture success? Strong leadership. Who is the leader? At the end of in a tough situation, who's going to make the final decision, but also who's accountable for the functioning of the team? Obviously, sports, it's the coach. In a different medical entity, it may be the attending, it may be a manager, it could be different people. But who is really ultimately responsible to be sure that team is performing at its highest level? Feedback. This is in every survey I've ever seen of any group. Feedback is always one of the biggest critiques. Everyone wants more feedback than they're getting. Mike's nodding, right? But how do you provide that feedback? Honest, constructive, productive, and always respectful. And that's one of the areas we struggle, I think, most with. Develop a strong sense of collective trust and confidence. This one's huge. Spent many years down in Tobacco Row, college basketball. You talk to the college coaches down there, and they all stress the same thing. For those teams, how do players trust each other, and how do they cooperate with each other, and how do they have confidence in each other? In a busy ICU, I have to trust the people I work with, because if I'm always double checking everything they're doing, I can't be doing my job. Of course, that takes time, it takes practice, but how do you have trust amongst your team and how do you have confidence that your team knows what they're doing and what they should be doing? Create mechanisms to cooperate and coordinate, and lastly, to manage and optimize performance outcomes. How is your team performing and what can that team do better next time? Effective team members. How are you able to predict the needs of other team members? To see your team member who may need help. And often I hear in what I do, do you need help? The question is not, do you need help? I see you need help. The question is, what can I do to best help you? Very different. Do you need help? No, I'm fine. What can I do to help you to do better? Or what can I specifically help you with? You get a specific answer back. Provide quality information and feedback, engage in a higher level of decision-making. Everyone should function at the top scope of practice. If everyone steps up to the top of what they can do, then the whole team steps up. As soon as any team member or groups of team members step down and fulfill a lower level of beyond their or below their scope of practice, that's when teams start falling apart. Understand roles and responsibilities, that's pretty straightforward. And this last one's important. Reduce stress on the team as a whole through better performance. It's a cycle. The more stressed a team is, the worse they perform. The other way, less stress, higher performance, but higher performance, less stress. Real key point. Teamwork actions. This top one is also a real vital point. Empower team members to speak freely and ask questions. Everybody should be able to stop the show. Whoa, stop. I'm uncomfortable. I see a problem. Everyone at any level, the brand new medical students should be able to say something. And I learned this many, many years ago in the ICU. It was July 1st, brand new fellow next to me, child codes. I'm running the code, the fellow's next to me. I asked for medication X, and this fellow sees medication Y go by that I couldn't see out of my vision. And he said, whoa, excuse me, I think it's the wrong med. That new fellow, comfortable enough to say something, made a difference. So everyone should be able to speak up. Again, utilize resources effectively and efficiently. Balance workload within the team. Unfortunately, we see this. 2 team members are running around crazy and 2 team members are on their phone, right? That doesn't work. Look for your colleagues, look for your team members, help them, have them help you. Delegate tasks or assignments as appropriate and do it clearly. I need you to help me with this, but don't point you, could you help me? Like no one knows who you is. Real key point, know your team members' names, at least first names. John, I need you to help me by doing this for this patient. Very specific and concise discussion. Briefs, huddles, and debriefs are huge. Briefs before an event, before a procedure, what's the plan? What is each team member going to do? Very similar to timeouts that are routinely done in our surgical areas. Huddles, each morning before a clinic, before an ICU day, bring the team together. Everyone knows what the operational issues for the team are, what safety risks are going to be, and what potentially could go wrong. Think about it in advance. And then debrief after an event, bring the team together. What went well? What could have gone better? And conflict resolution, it's beyond the scope of what I can talk here this morning, but obviously conflicts happen, and how do teams best manage conflict within the team and also between teams. Situational awareness, we come back to this. It's the state of knowing the current conditions affecting the team's work. Know the status of a particular event, know the status of a team's patients, know the big picture. Real life example I had just this past week. We're in busy ICU, full unit, high acuity, and one of the patients, the sickest patient, needs to go to radiology. So we're going to have a situation that we're going to take off the unit, the attending, 1 provider, 2 nurses, and an RT. The rest of the unit needs to know that for that next hour, resources are limited. If they're going to need help, think ahead. But the team that's leaving has to think about, are there any other fires burning? Is there anything else going on in that unit that maybe this isn't the right time to go? And if you don't have that communication, that's when things go astray. And shared mental model, and I love this apple analogy. I'm thinking of an apple, Joyce is thinking of an apple. We're not looking at the same apple. Thinking about the same situation similarly, and how to get the team members to do that. It takes practice, it takes time, and most importantly, it takes communication. So lastly, teamwork actions, just some concepts Foster a climate supportive of team assistance, support a questioning attitude. Everyone should be able to ask why and ask the question, what are we doing? Provide timely and constructive feedback, resolve conflict through collaboration, creating win-win situations, and be assertive and advocate for the patient, always in a non-threatening, respectful way. That I will turn it over to Kate Golnick, our Manager of Safety, for the next section.
Good morning, everyone. For those of you who might have never seen me or met me, my name is Kate Golnick, and I'm your project manager for safety here at Rainbow. This next portion is going to piggyback well off of what Ira was just talking about. We're going to talk about a couple of tools that promote our teamwork in these settings and in our everyday work. So every Tuesday, for those of you who might not be aware, we teach a class called safety training. It used to be called error prevention, but as we move into the safety 2 mindset, we're kind of moving away from the word error. It holds a negative connotation and sounds punitive. So we're really looking towards a psychologically safe environment and focusing on that safety aspect of our patients and our employees. When we teach this class, we set behavioral expectations for everybody. One of these behavioral expectations is to have clear and complete communication. So we like to say, I am personally responsible for concise, accurate, clear, and timely communication. To do this, we have 3 tools that we like to use. We have SBAR. We should all be well familiar with SBAR: situation, background, assessment, and recommendation. What I do like to say about SBAR is that we have to remember it's not a handoff tool. SBAR is an action tool, right? We have 3-way communication and clarifying questions. 3-way communication. We have a sender, communicates. We have a receiver who reiterates. And then we have the sender again who confirms. And then clarifying questions. Ask all the questions in the world. You know, as we get older, as we get further in our careers, we tend to ask less questions, right? We become more comfortable in our environment. We think we know. But if we don't support that questioning attitude and we don't keep that open mind, we might not be open to suggestions and we might miss something, or we might not have added value to a situation. And then we also have our standardized handoffs. We use this every day when we get a new patient, before shift change, after shift change. Very well utilized here. And then we also have a behavioral expectation of supporting that questioning attitude. We say, I will question and I will welcome being questioned. 2 of these tools, 2 tools that we utilize, QVV, qualify, validate, and verify. You know, we want to make sure that this source is accurate. We want to make sure that this source is trustful. And we want to make sure that this source is coming from an expert. And then we also stop and resolve. As we all like to say, don't proceed in the face of uncertainty. You know, they're not going to throw me into the surgery room and say, go ahead. I would say, no, that's out of my scope, you know? So you stop, you're thinking, and then you're utilizing your teamwork or your teammates in that communication to resolve a potential problem. We also like to utilize huddles and briefs. I know Ira touched about this last portion, but a couple studies say, or we found that studies have shown, huddles positively impacted team process outcomes in 67%, my apologies, of studies. They've improved in efficiency, process-based functioning, and communication across clinical roles for 64% of studies, and situational awareness and staff perceptions of safety and safety climate for 44%. And then in 29% of studies, it increased staff satisfaction and engagement. So when we're bringing those key players to the table and we're huddling and we're level setting and we're communicating, it increases all of these things across the board. So a couple of reasons why we huddle and why we brief. As we said, it facilitates open communication. When we have all those key stakeholders, it's easier than asking this person and then asking Joyce and then asking Muna and then playing telephone. When we're all there at the table, we're making sure we all receive the same exact communication at the same exact time. It brings shared awareness. You know, as Ira said, everyone should know what's going on the floor that day. We should know who our highest acuity patient is. We should know who's drowned, like what nurse or what physician might have the most patients. We should know what's happening in our environment. It also increases enhanced decision-making. When I have people giving me advice, I'll take that any day of the week. And it also helps us proactively address potential risk. And then we also align the entire team around patient safety. It just helps us level set, it helps us communicate and make ourselves ready for the day. And then this leads us into our case study. So I'm going to pass it over to Dr. McCallan.
Thank you, Kate. For those who may have joined after the initial intro, I'm Tracy McCallan, the Associate Chief Quality Officer for Education. And we wanted to just share a case where we can see these tools and teamwork aspects in real action. So this is a hypothetical case, but it is based on details of cases that occurred here at Rainbow. This is a 14-year-old female who came in admitted to the inpatient unit on PCRS from the ED, had an asthma exacerbation and influenza A. Patient has a history of asthma, has had prior admissions, one to the PICU, and recently has had 3 days of increased wheezing, work of breathing, not responsive to home bronchodilators, has become febrile since the evening prior to admission, and decreased PO intake. This is initial vital signs from the admission at 2 a.m. You can see here the patient was febrile, tachycardic, had saturation of 94% on 3 liters by nasal cannula, and was sleepy but seemed appropriately interactive, was somewhat short of breath with speaking, had fair air exchange, scattered wheezing, but symmetric breath sounds. Cap refill was a little delayed at 3 seconds, but pulses were good. And again, felt non-focal neurologic exam, sleepy but arousable. Labs showed elevated white count of 18,000, had chemistry that was remarkable for bicarbonate of 15, BUN of 24, creatinine of 1.1, so did look to be dehydrated, pre-renal, maybe a slight AKI, and was influenza positive. Initial management had been placed on the asthma pathway in the ED, started on moderate pathway, had a clinical asthma score of 4, continued on the asthma pathway, and was admitted on Q2-hour treatments initially to the inpatient floor and was started on Tamiflu for the influenza. Also given IV steroids and IV fluids. Approximately 2 hours later, with the next check and vital signs on the patient, the sepsis BPA fired in Epic, and you can see the vitals here again was febrile, a little bit more tachycardic, blood pressure was a little bit lower, respiratory rate slightly higher, SATs again low 90s on 3 liters nasal cannula. The resident team evaluated, sent a blood culture, and started ceftriaxone, concern for possible pneumonia on their exam. Over the course of the evening, patient continued to deteriorate. By 7:30 at change of shift, the oncoming nurse was concerned about the continued fever, progressive lethargy, and work of breathing. The overnight nurse had notified the team again at 6 a.m. about these changes, was reassured they felt the patient was okay, had seemed tired because of the frequent overnight checks and breathing treatments. Thought the tachycardia was due to the fever as well as the albuterol, which kind of confounded that a little bit. Already was on antibiotics and felt the asthma management was appropriate. You can see here vitals at 7:30, just again, slowly trending in the wrong direction. At 10 a.m., the nurse called the intern on the team to express similar concerns, questioned whether a PACT should be called because she was concerned. A Pew score was not obtained at that time. The intern provided reassurance, indicated they were rounding, and the team would be there soon to see the patient. At the time of rounds, when the team evaluated, they found that the patient was sleepier with increased respiratory effort, and the PICU fellow and charge nurse were called for a direct transfer. You can see 11:38, the fellow, charge, and RT arrived at the bedside, noted the patient was lethargic but maintaining airway, had started a bolus, had started on non-rebreather, given continued delayed cap refill, and was not appearing to be moving air well and transported to PICU. Very shortly after arriving in the PICU, patient then became hypothermic, very tachycardic, hypotensive, was only saturating 84% on non-rebreather and therefore was intubated. They placed a femoral line, started a vasoactive drip, repeat blood cultures, and added vancomycin. Unfortunately, even with the escalation of care, the patient developed fulminant septic shock and succumbed to multi-organ system failure 3 days later. And blood culture eventually grew MRSA. So this is an example. Whenever we have a mortality, it's always a very difficult situation for all involved. And we want to try to understand what happened and how we can try to help prevent something from occurring in the future. So a serious safety event like a mortality will go through an RCA, root cause analysis. And this is an example. These were factors that were identified in cases similar to this. The sepsis huddle occurrence, we just heard from Ira and Kate the importance of huddles, and that did not occur in this case, although the trigger fired, that needs to be tied to the sepsis huddle OPA alert. And so that was work that's been done in EPIC. We have escalation pathways, which we'll be speaking to next. What is a direct transfer versus a pact versus a code, and understanding the processes around that, making sure that those are well in place and that teams understand the criteria. Escalation using PEWs, that wasn't utilized in this case, so reviewing that within the escalation algorithm and how do we integrate that into our daily care and rounding. And then we've talked about communication. So it was challenging in this situation for the nurse to escalate beyond the resident team if they felt like their assessments weren't congruent. And we have had a lot of great work on collaboration with residency leadership, nurse and resident communication committees, and work being done on the floors. And I'll turn it over to Muna, who is our principal project manager for quality and has been doing a lot of very important work on sepsis.
Hi, morning, everyone. So we have been part of a sepsis collaborative and doing quite a bit of work on sepsis improvement for about 5 years. So I'm going to try to take that 5 years and sum it down to about 10 minutes and just talk a little bit about what we have been doing and what we are still doing and really what's to come in terms of our sepsis work here. Rainbow joined a national collaborative called Improving Pediatric Sepsis Outcomes, or IPSO, that's hosted by Children's Hospital Association in 2020. At that time, Dr. Macios was one of the co-chairs of the collaborative and currently serves as our executive sponsor, and is our current chief quality officer. In general, the sepsis collaborative had about 50 to 52 different children's hospitals across the country. Children's hospitals joined at different times. We were one of the last hospitals to formally join, so we were part of phase 4. So we had the opportunity to learn from some of the other hospitals that had been at this a little bit longer and had done much of had been already in the process of doing the work. In general, it's a quality improvement collaborative. So the collaborative was very much focused on implementing 5 key processes that we know can improve sepsis outcomes. Those are processes related to recognition, so things like screens, huddles, and order sets. And then the other 2 are time to antibiotic and time to bolus. And we'll talk a little bit about the sepsis bundle and what those elements are. When we joined the collaborative, our first thing that we did is we established a Rainbow Sepsis Coordinating Council. The Sepsis Council was made up of 4 different teams: the emergency department, the intensive care, inpatient units, and then HEMONC. And as we put each of those different teams together, we asked each of those teams to select a physician champion and a nursing champion. And then at some points, we also had different pharmacy champions that were part of the work. The Sepsis Council met often. That idea was that these 4 teams were working somewhat independently, or they were working to address it in their own team, but then we were coming together once a month or every other month to really share our work and think about where that work could be systematized. So things like developing a shared clinical practice guideline, things like developing EPIC and how that could work together. So that work continues. And at this point, we are continuing to meet. We're just transitioning to every other month again. So again, as I said, that Sepsis Council, we would come together as a group and we would develop guidelines, and we were really working to implement those 5 key processes, i.e. the sepsis bundle and the elements of the bundle. So there are 3 different parts to the bundle. The first one is recognition. Recognition is either there is a positive screen, a huddle that is positive for sepsis, or the sepsis order set has been used or initiated. The second piece of the bundle is if we recognize sepsis, we want a bolus to be given within 60 minutes or within 1 hour. And the third part is an antibiotic within 180 minutes of recognition. So that is the general sepsis bundle. But we know that for some patients that are really sick and maybe would be what we call sepsis red, and we'll talk about that in a minute, that are more critical, while our bundle remains the same, our goal is shorter. So for patients that are sepsis red, the goal is reduced to 30 minutes for the bolus, and then the goal for the antibiotic is reduced to 60 minutes. Again.
Diagnostic opportunities, recognition, or, capturing the recognition piece of that diagnosis and treatment were the two top things, which tie in nicely to what we said.
Yeah, thank you so much. Yeah. And so as we were developing our guideline and learning from other organizations, what we had found is that this is like Joyce said, there's a lot of opportunity. It's tricky and it's hard. Like in the moment, how do I know if I put them on sepsis red or sepsis yellow? And we'll talk about this. Or, it evolves, right? It's not a clear linear process. We know that there is sepsis really is a spectrum, and there could be infection that again the patient worsens, and we saw in that case earlier today. So what we've tried to do is develop these two separate pathways to help folks like operationalize how I would do that in real time when I'm caring for my patient. So we have the sepsis red pathway, and the sepsis red means my patient has sepsis or has septic shock. Typically, that would mean that there are signs of organ dysfunction are present. This patient needs urgent care. So when I place my patient on the sepsis red pathway, or I say in my huddle, we're going on sepsis red, that our goal is that is what that means, as opposed to sepsis yellow. Sepsis yellow is this patient maybe has sepsis, likely has sepsis, not ready quite to say it yet, but there are could be some signs of organ dysfunction. The patient maybe needs a sepsis workup. The patient is stable while receiving ongoing sepsis care, or this also is maybe an oncology or immunocompromised patient that has a fever. So we really encouraging to use the words suspected sepsis, sepsis yellow in these patient populations. And then when they're on the floor, a patient who is placed on a sepsis pathway is encouraged to be made a medical watcher. If we're putting them on a pathway, that means that patient likely needs closer monitoring. And we want those patients to at least initially be a medical watcher, monitored closely for clinical deterioration until that team then comes together and makes a decision, a watcher status is no longer needed. So these are some of the things that we have been teaching through our sepsis council, through our guidelines and our pathways. When it came time for us to really double down on our efforts to teach this workflow and this pathway and to build it into Epic, we sat down again and we made another process map. So I have a lot of pictures here. I'm not going to go through all of them, but really we found that our staff really needed explicit, help us through this step and process, because this is really hard. When I'm faced with this at the bedside or when I'm working through my teams, it's not linear, right? So how we really wanted to try to make it very direct and very clear what to do. And so we put together this process map, and the idea is something makes you think sepsis, right? So either it's a OPA in Epic that's been turned on for that unit, or potentially it's that gut instinct, or perhaps your floor has a standard that, hey, if the temperature reaches this critical threshold, we think sepsis. So wherever that might be, if you have a concern for sepsis, there is a trigger or screen. The next thing you do is you directly communicate with the medical team, and you notify that team right away. We do have alerts, as I said, in Epic now. Not every floor even does have them, but we often say that alert does not replace direct communication. Those alerts are required for someone to actually physically open the chart to see them. So just because there's an OPA doesn't guarantee that someone has seen those yet. So it's really direct communication. And then the next thing is huddle. We've heard huddle, 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 right? Huddle at the bedside, say out loud, I'm concerned about sepsis. Is this sepsis? Really ask those questions, discuss a plan out loud, and then make a huddle decision. Are we going to place this patient on the sepsis red pathway? Are we going to place them on the sepsis yellow pathway? Or are we not concerned about sepsis at this time? And we call that sepsis green. Okay. Once that decision is made, placing stat orders is important. And that's when you're really, implementing those time-sensitive interventions like the antibiotic and the bolus. And then treat. And going into treatment. So sepsis red and sepsis yellow. And then, of course, documentation, monitoring, and following up. And you can see the notify triggers, the huddle, and the orders. All three of those are different recognition processes. And when we get to some of the metrics and data, I'll show you how we're able to measure some of those. So again, we had these process maps, we had these guidelines and these pathways, and staff still were saying, it's very, it's really hard for us to walk through what this actually looks like. And so we had a quality curriculum team that started working together in May. It was made up of two providers from the PCICU, someone from a provider from from PCRS, floor nurses, pharmacy. We had a really nice group that came together. And we actually walked through this process and what that would look like. And we landed on another visual depiction of the pathways. And this was a little more impactful to the clinicians. They liked this version better. So again, sepsis green, sepsis yellow, sepsis red, and what to do. And so it kind of mimics a lot of what I already shared with you. But this was designed to be our standard workflow. And this is what we have continued to teach to staff. We are teaching on some recurring basis. We've started to do some simulation where we take some different cases and we simulate and we go through the case, we sit around and we talk about it and we pull some of these teaching documents and we think about what that would have looked like and what we would have done. So those simulations are still ongoing, et cetera. But this was really a product out of that quality curriculum team. And so then as we walked through that like really detailed process, right, we had to go back to Epic and we had to rebuild the screens, the sepsis screens, and we had to rebuild the way the huddle prompts so that it happens at the right time. Because what we found is when we went through that workflow and we designed it, the prompts weren't really coming up at the right time. So this is what I guess is a bit of a functional map, but this is really how does the IT interact with the human? And this was really our effort to kind of build a pathway and go through all the steps. And this is what I worked with the Epic analyst to help her understand where we need to see these pop-ups alerts so that it's at the right time. Again, not to go through all of it with you, but this really does take you step by step. We have like 3 or 4 of these built now for the different units because they all have different alerts and slightly different processes. Okay, and then finally, the clinical decision support, the provider huddle, the huddle that we've been talking about. So wherever those triggers come from, they all lead to a huddle OPA. So right now we have one huddle OPA in Epic that looks the same. That's going to slightly change in the future, but that shows to the provider once an alert has fired. And you can see in the actual huddle OPA, we provide the contributing factors. So why did this trigger? What was the rule that turned it on? And we display anything abnormal in red. There is a link to the clinical pathway and clinical guideline in the middle. And then the provider right from this OPA can also open the order set. And we're asking them to make a decision if this patient is going to go on one of the pathways, yes or no, and then to accept it at the end. Even if that OPA is initially dismissed, on the left-hand side over here, you can see for those on Zoom, where it says sepsis huddle, that just means a huddle is waiting to be documented. So if it's been dismissed once and someone else opens the chart and you see that, it means there's a huddle that has not been documented and responded to. Yes. Mm-hmm. Yeah, absolutely. So the question was for 3 hours, antibiotics seems long. So the international guidelines that, for sepsis, they initially, I think our goal was that golden hour, that 60-minute rule. So 2 things, when they were looking at all that, all the data that had been collected, well, I'll take a step back from Ipso. So Ipso has been collecting data for a number of years. When they aggregated all of that data and looked at the outcomes, the risk difference for those outcomes was greatest when the antibiotic exceeded 180 minutes of administration. And that was for all patients. They aggregated the data and examined it for different time points and different bundles. And what they found is while we might say 60 minutes is better, 60 minutes felt very unattainable for some situations. And it also didn't always allow that diagnostic workup or opportunity to reflect on antimicrobial stewardship. So 180 minutes for someone that might be suspected sepsis, or we're not sure, we want to allow some time for workup. That is really the cutoff where outcomes really worsened and where they saw some poor outcomes. So that's why we say for sepsis red, yellow altogether, it's 180 minutes, but for sepsis red or those more critical situations, the goal is 60 minutes. And then also, again, that's actually aligned with the international guidelines for sepsis as well. And it's really that evidence of organ dysfunction where that 60-minute critical time point becomes more significant. Anything to add, Dr. Macias? Yeah. Okay. So then I know we're probably over on time, but I did want you to know that we do monitor a lot of this since we since we did that quality curriculum project and have fixed a lot of these different timestamps and these recognition processes in Epic. We are really trying to collect data and give folks feedback and let everyone know how we're doing. So we're able to track sepsis mortality. We're looking for sepsis episodes with recognition. And then if there is a recognition, we can assign a time 0 that gives us a starting point. So we have recognition, we can measure time to bolus, time to antibiotic. I have other depictions where we differentiate this for sepsis red versus sepsis yellow. We're able to filter this by the unit and by the team and start to give folks some feedback. So this was just really released this past December, and it's not widely published yet, but we're really excited to be able to give folks some meaningful feedback and really help us improve these outcomes. Just a quick snip, the ED has been at this the longest. So their data is a little bit cleaner, but you can see this is just a run chart to show you how our sepsis compliance rate is. This is really back post Epic Go Live. We had a lot of technical issues, and you can see consistently 95, 97%. And then ED huddle compliance, again, prior to Epic, did not have a way to force that clinical decision support and document the huddle. We've worked to address that in the ED for the first time really ever. We're now reaching that consistent greater than 80%, approaching 90% huddle compliance, which is really awesome. And then following that quality curriculum project that we worked on together, again, in the spring, we found that there were issues. We did a lot of fixing, a lot of addressing those issues, and we found that through our education and through fixing those items in Epic, we're able to bring the huddle compliance, or I should say huddle documentation following a prompt. This data is only on Horvitz Tower 5 and Horvitz Tower 6, and we continue to do work with them and continue to have opportunities to optimize that for sure. And then finally, sepsis mortality. So we went a couple of years without a sepsis death, and we had one at the end of 23, one in 24. And again, we monitor this, and we're working hard to improve our outcomes. This, I think, will answer the question that there was in the chat regarding why did we come up with this bundle. So this is that data that is an aggregate of the cases that were submitted to the collaborative. So again, recognition, bolus, and antibiotic. When they looked at these cases and they compared a patient that was all or none, so either you were bundle compliant, all those elements were there, or one or more of the elements were not there. Compliant versus non-compliant in patients with what we call critical sepsis. So critical sepsis means your patient required a third IV bolus or was placed on a vasopressor. The risk difference in sepsis attributable mortality was almost 50%. And then for that suspected sepsis, so that sepsis yellow, or that patient that we maybe were doing a workup, we were not sure at first, for those patients, compliant versus non-compliant was an 80% risk reduction. And this is really the data from the collaborative, which again aligns with the literature that's what the cutoff that we're using. And then just to let folks know, we do also submit some secondary outcomes. So when we were submitting data to IPSO, we were also counting vasopressor days, counting antibiotic days. And this is data likely from wave 1, where we're able to show some other secondary outcomes that were improved related to hospital days, end organ dysfunction, and prevented ICU days, vasoactive days, and ventilator days. I'm way over. I'm not too much. Yes. It does not. Thank you. No, our mortality at this time does not include the NICU. It's really from those other 4 teams. Yes, and it does not include patients whose time 0 occurred outside of our Rainbow proper or Rainbow ED. Thank you.
Hello. If you don't know me, I'm Dave Spicer. I'm one of the ICU attendings and one of the co-chair of the resuscitation and escalation committee. In kind of going from recognizing sepsis, I'm going to talk a little bit about how we get help if we do recognize sepsis. So this is everything you need to know about how to get escalation of care in one document. Obviously, this probably won't have to be memorized, but this is a reference chart that's available. This is on the digital workplace. It's attached to the policy on escalation. It used to live in every workroom on every floor. It's probably buried behind 5 or 6 other pieces of paper. But in general, this is kind of everything you need to know. To kind of put this down into one statement, When in doubt, if you're worried about a patient and you need help fast, call a pediatric code blue. That will get you help fast. That will get everyone you need to the bedside as quickly as it can. If you need help fast, don't worry about anything else. Just call a code blue. And it can be anyone. It doesn't have to be the attending. It doesn't have to be the senior resident. It can be the PCA. If someone is deathly worried about a patient, please call a pediatric code blue. But this, so that was my little soapbox, and I'll get back. But the rest of this, we have a multi-tiered kind of system of escalation, and all of these things are part of it, and we'll go through them each a little more concise and kind of a little more in depth. So the first one is I need to get my patient to the ICU. So I have a patient that is there and they need the ICU. There's really 3 ways to do it. The first, most important, I need help in less than 30 minutes, is call a pediatric code blue. You do not have to be doing compressions. You do not have to be bagging a patient. I'm worried about a patient. This patient is sick. Going back to that sepsis kind of case study that we went through, probably the stuff around midnight the night before didn't need a code blue. But that morning when you had a change in mental status, the patient wasn't as awake as normal, was having respiratory distress. We weren't doing compressions. We weren't starting epi, but there was enough problems there. There was enough illness. Please call a code blue. So that's over here. So if you are worried, call a code blue. There's 2 other ways to kind of get through, talk with the ICU. It's sometimes a little fluid, depending on our bed status in the ICU. On Monday, when we had very few patients, we would be thanking you if you called us. Today, when we're a little full, it's a little tough. But if someone meets the criteria for the ICU, so you have an asthmatic that you've had to escalate and they're on continuous albuterol, call the ICU. If we have a bed, we will take that patient kind of as a direct transfer. In general, what we've established for time norms is it's 30 minutes for us to kind of get the bed ready. So you call us, we kind of have that 30-minute period. Most of the time when we actually looked at kind of our data, we were ready a lot faster than that, but it kind of gives us that period where we're on the full side. If you think a patient may need an ICU, or I just need help, or I am a nurse and I want someone to have an extra set of eyes on a patient. So that's where we have our rapid response team, which at Rainbow we call our PAC team, which is our patient advocacy for care team. And that's just something is off. I want to kind of see someone else to come see that patient. So again, it's a rapid response. You get an ICU fellow or attending, you get an ICU charge nurse, a respiratory therapist. They have 30 minutes to respond. When we looked at our data, our average time was somewhere less than 15, usually less than 10. But again, depending on the acuity of the ICU, they're also running the ICU at the time. So they have up to 30 minutes to respond. And really that's not for the patient that is having lots of problems. That's for hey, maybe someone just needs to come take a look at this kid. It's a broncholytic that maybe we need to start high flow on. It's that second set of eyes. This kind of went through everything I just talked about. One of the other ways to get a PACT and kind of one of our systems that we have established is our PEWS system. So PEWS is our pediatric early warning score. And it really is based off of 3 categories. So there's a neuro category, a cardiovascular category, and a respiratory category. You get a score. Everyone is scored as an inpatient every 4 hours. And then based off of that score, you kind of get entered into an algorithm. And really all this algorithm does is promote communication. It brings people to the bedside. So if I get a 3, and the first thing that happens is it's not a PAC consult, we bring everyone together. So the nurse, the charge nurse, the intern, the senior, they eventually talk to their attending, but it's that huddle that we talked about. It's bringing everyone together to kind of hopefully get a shared mental model of our patient and kind of escalate care as needed. This runs in the background on all of our patients. It's there. It kind of establishes when we kind of escalate care. It also kind of takes away some of the subjectivity of calling a PAC consult. Anyone can call a PAC consult at any time, but at some points there's times where you have to call a PAC consult. So if you look back here, so a teenager, it was a 14-year-old that we're talking about, to get a PEWS score of 6 or 7, which automatically gets you a PAC consult, is a teenager who's probably got a heart rate in the 140s and is breathing 50 to 60 times a minute. Like, that's a sick kid. So if you're kind of down in this portion, I lost my pointer. If you're down in that 6 or 7 period, like you probably want a pack consult and you want a pack consult quickly. So our next kind of level before we get to that path consult is our watcher program. And this is something's just not right about this patient. So going back to that sepsis patient that we went through, this was the kind of period of time, that 10, 11 o'clock at night, where everyone's like, there's just something not right about this patient. This isn't our normal asthmatic, but it's not they're not having a high Pew score. We don't think we need the ICU to come, but again, we need to improve communication. And really the watcher program, again, is just a standardized mechanism to improve communication, to bring everyone to the bedside. It involves 3 processes. So identification. So someone's worried about the patient. We have a list of kind of things that people are worried about, but most of the time, and what triggers it a lot, is just something's not right. There's something about this patient that makes me worried, and I'm going to place them on the watcher program. Identification, we then get a huddle. The team at the bedside, along with nursing and the residents, come up with a medication plan. So this asthmatic is the respiratory rate is going to improve within the next 2 hours with continuous albuterol for those 2 hours. If that doesn't work, if that kind of doesn't fix the problem, then there's escalation. We're going to call a pack consult. We're going to do an ICU transfer. Every 4 hours, we get the team together at the bedside, again, bringing everyone together, not sending text messages, not kind of actually coming to the bedside, talking with the family, seeing the patient, getting everyone together. And that's kind of the most important part of why we like our watcher program. Yes. Oh, hi.
So lawyer's dream, thank
Yeah.
you very much. Question, how is that documented? Because that becomes such an important issue if there's a bad outcome despite everyone.
So so the question was, how is our watcher program documented? So the identification portion is in Epic. Thank you for that. And it's actually checked off by the nursing staff. So if they have a criteria, they will go through this. I think this is from our old EMR, but we copied it into our new EMR. But they kind of what their watcher criteria was, why they created it, and then it creates a flag in the EMR. The huddle at the bedside is documented by the resident physicians. We actually have a standard note template, which is was updated probably a week and a half ago. The chiefs are hopefully trying to get that out to everyone. But there's criteria in that watcher note that kind of need to be met. Did we notify the attending what the outcome is, what our worry is about the patient, what our mitigation plan is, what our outcome of that mitigation plan was, and then our escalation if something bad is not going to happen. So all of those things are in that intern resident note that's present in Epic. And the quality team actually tracks those to make sure we're doing that well. So identification, about that. So mitigation, again, these all get documented in a note, and again, it's all in the communication portion of it. But we said why we're doing it, our vital signs, what we're going to do about it, and then when we're going to get better. And then what do we do if there's escalation? Oh. So there's a question about adjusting Pew scores. So there's actually a policy on how to do this. I took the slide out, but it's there. So there's a kind of multi-tiered system to agree that everyone can kind of adjust a Pew score. It usually has to be initiated by the attending on the floor kind of record. We've established that they have to see the patient that day and have examined the patient. This is kind of to stop that 2 in the morning, the intern doesn't want to get called anymore and changing the Pew score. The attending kind of has to evaluate it and agree with it. They have to speak with the nurses on the floor to make sure that, again, there's a shared mental model. Everyone's comfortable with adjusting this Pew score. The ICU has to be notified that it's happening, just because so they're aware that this is happening out there. But there is a policy in place on kind of how to change the Pew score if need be.
Situational awareness, I think, is beyond the internal team or the team on that unit. They're brought up on the daily safety brief when we talk about medical or behavioral watchers. And there's also the flag in the patient list parameters where you can see someone who's been flagged as a watcher. So that would be an eye to Dave to see if the ICU attending, like, who are the hot spots on floors that an attending might get called or the victim might get called to come and see.
It allows Jen as a nursing leader to see where those, again, you can references it frequently.
Yes. Yeah. So online, Joyce just talked about that it's more than just a local issue, escalation of care, and that all of these things feed into our daily organizational safety brief, a flag and Epic, kind of ICU notifications and things like that, so that hopefully our entire system and definitely our hospital is aware of kind of where our hotspots are. And then my last slide is briefly just talking about how we monitor how these things are going. So we use a measure that's part of the Ohio Children's Hospital Association and Solutions for Patient Safety, and that's an emergent transfer. So this is someone who goes to the ICU and within an hour gets intubated, gets put on vasoactives, or gets over 60 per kilo of fluid boluses. If you compare our numbers to our similar sized Ohio hospitals, we actually do quite well. In 2024, we had a grand total of 7 emergent transfers. These are all comers. So we don't look at preventability. So like our last 2 in December, one was a trach patient who plugged their trach and one was an anaphylactic reaction who got intubated, probably not preventable. The one that's circled there is sepsis. And our goal is to really look at that. We report every one that happens, but we do kind of assess preventability and are trying to work on those cases in particular. And I think that's all I have. And I'll leave it to Lynn.
Hello all. Need to put my old lady glasses on. Sorry. First of all, that presentation was amazing, and I have had the privilege of serving Rainbow and its board for most of my career at UH. And if you don't recognize it, you guys are above and beyond in your quality measures and what you do about prevention. It makes my job much easier. And that whole presentation about actually building this into Epic with flags is what makes everything better. The thing I can add as a lawyer who deals with the bad outcomes, and there will be bad outcomes despite everyone's best efforts, is documentation. That's the one thing I can add to the flavor of the first part of this presentation. If you are going to make a decision that's different than what is flagged, that's okay. You guys have clinical judgment, you see kids, you have instincts, document why. I can always defend it later, even if there is a bad outcome. So I can't express enough the human factor. There's all these great flags. I mean, I'm watching this in awe, like, thank God there's a trigger, there's a do this, then that. But sometimes it doesn't feel right, it isn't right. Just make sure you document that, and we'll work with it if there ever is a bad outcome. So my colleague, Sarah Stover, and I think Sarah's around here somewhere, there she is, have been invited kind of to do the second part of all of this. And I think it really makes sense in what do we do when bad things happen? And there are things we can do to help our caregivers and also to prevent litigation, or if there is litigation, to be best able to handle it. So that's what Sarah and I are here to talk about. And then Sarah's going to talk about something that we have worked with all of your leadership. And I see all these faces. You guys are having more and more behavioral health patients that are parked at Rainbow and that come in through our ED. And Sarah really has worked with like most of these cases remarkably to help you handle these issues when they land in Rainbow, because they land in Rainbow not for a day, not for a week, sometimes for months and months. So the law department is here to help you. That's the other thing. Everything you say to us is privileged. So we really are here to help. My kids were Rainbow babies. They were one of them was even a NICU baby. Rainbow is close to my heart. And you know, Sarah is a nurse by training first. So there's a lot that we care about here and kind of are right there with you. These are very busy slides. So I'm going to talk more than I'm going to read them. We have invented at UH and seen a need for a high-level risk event escalation and resolution process. So it's an initiative that's come into play with legal, with our enterprise risk management, and with clinical risk management as a way to elevate quickly events that can affect caregivers, number one, and then litigation, number two. So I want to talk to you about the criteria and kind of how to trigger this. It is GM 108. It does have a policy. It is still in motion. We've used it a handful of times, even at Rainbow so far. It needs a little bit of tweaking, but this event was happening now. So it will be rolled out even more than today, but just wanted to kind of preview it to this whole group Maybe you'll point out things that don't work and we can bring that back to the group that's putting that in place. So why are we doing this? Obviously, it makes life easier for the institution if we can identify litigation exposure early and sometimes resolve cases early. In my tenure at UH, I have met with families early on and resolved more cases than I can count. It takes the temperature down. I think families feel heard and seen and supported in a difficult outcome. And when you rapidly escalate these kind of events, we really can both help the staff that may have been involved in the care and are very distressed, and also mitigate institutional risks. We think it's really, really important to get people together quickly when this happens. And that's the main reason for doing this. Also, there may be a need for disclosure, or there may not be, and that tags along with all of these events. So it's important to get the right people together in the right virtual room now. Zoom and phone calls are wonderful, and figure out what next steps are. Also, there's often, when something really difficult happens, especially with kids, media. And you'd be incredibly, the media ignores a lot of disgruntled patients that call, but when it's a kid, the media pays attention. So we also want to get our arms around that issue in case there really is nothing that we did wrong, but it's a very difficult outcome that may garner media attention. Also, I want to help you with documentation, because in the end, pediatric cases, I'm sorry to all of you, have a statute of limitations of the age of majority +1. So we can have a 2-year-old that we may not see a case until they are 19. Have we had it? Yeah. It's usually newborn cases. I will be very candid. The ones that last a long time are often newborn cases, but in the last 2 years, and we won this case, we did have a miss on meningitis in one of our outside urgent cares that came 10 years after the child had this happen. Medical records changed. Those were paper records. A lot of things change, which is why that documentation becomes so important. So what is the criteria? And I'm not going to go through these blow by blow, but and it will be in a policy that you can all see. But the issue really is there something that is going to rise to the level of litigation, media attention, bigger harm? Did we find out that our sterilization machines are not working right? So it could be many, many patients, that kind of thing. And then anything else that feels like it's bigger than normal. And the good part about this is it's just escalating it to a first phone call, and I'll talk about that in a moment. And then we can decide if we really need to go through this whole sort of escalated, quick RCA process. And by the way, your root cause analysis process at Rainbow is so far advanced over anything both in UH and outside. It's 3 steps. You recognize you may have more information as time comes that's relevant. And so it's a really robust process, and this sort of puts it in high gear. What I would say is pediatric deaths that are unexpected are kind of I would say almost always, let's trigger the phone call. It may not go beyond the first phone call, but let's trigger the first phone call. And let me go through where we are. Oh, I guess the other one is sexual assault, homicide, or suicide. Oftentimes I say, let's make that first phone call. It may not result in anything, but that makes news, which is why that's sort of in this bundle as well. And by the way, these will be available and it will be in the policy, which is why I'm not reading them to bore you right now. So what do we do when we escalate? Another great flow chart. God, I hate these. The bottom line is that there's 2 different ways to escalate. One is during business hours. One is during after hours, because when does everything bad happen? After hours on the weekend, as we all know. The bottom line is you're going to get to the administrator on call, who will very quickly call risk management, who will trigger that first sort of triage phone call. And there'll be a lot of different bodies that, per the policy, are invited to that triage phone call. I'd like to empower anyone to get to that administrator on call, and that's going to be the important thing. There may be, a resident, a nurse, someone that was involved in that care that has the antenna to say, I want to get this to somebody. It's all privileged because it's coming through risk first. And my message that I will put out to all of our caregivers is, when in doubt, trigger it. We can always say no after that first phone call. It's a 15-minute phone call, kind of gets all the right bodies in the room to have it. And those are who are in this lovely chart that I did not create. but we would rather have 20 first phone calls for one that matters. And we'll get better at this as time goes on and the instincts will get better. But really that first phone call is no skin off anyone's back. You know, Sarah and I take calls at 2 a.m. There is an attorney on call for our system 24/7, 365. And that's the person that will be at this first phone call. They may be a corporate transactional attorney, but they know enough about healthcare that if it's going to go to the second level where we start with the RCA meetings, one of the attorneys likely from my team will then get involved. So off hours and holidays, it's kind of the same, except that there's alternatives within the law department that happen during the day and risk management that happen during the day that may not happen overnight. So basically just make sure that the leader, whoever the leader is around at that moment, gets to the administrator on call who will call risk that will trigger this. So that's really the flow chart. We can take all of the rest of this out of the mix. The other thing I will always say, when in doubt, if there's something like this, there's an attorney on call 24/7 and you just call the UH pager and they will get that attorney on call. So if somehow you feel like the wheels aren't in motion, things aren't happening, it's something that you intuitively know, we need to get to this and we need to get to this quickly, that's a privileged phone call and you can do that. We are perfectly fine with even, you know, it's supposed to be the administrator on call, then to the attorney on call. And that's for these events that you don't really need an attorney. This may be consent, this may be some of these other issues. Something that you think rises to this level, go ahead and get to the attorney on call if we're having trouble escalating this. Like I said, it's a policy very much in its infancy, a really important policy, but we don't want to miss opportunities to escalate in real time because in terms of the caregivers, in terms of the families, that makes so much difference, especially if the family needs handholding or the caregivers need handholding while this is going on in real time. So this is what the brief call. Risk management finally initiates this brief call as soon as possible after the administrator on call gets in touch. And the real purpose of the call, so you can figure out who needs to be there, is key information that's known at this time. So many things are speculation when this happens, including could the outcome have been changed? And we get that and we understand that. And this is really to figure out, number one, to give support tools for the documentation of the event. It's an opportunity in a privileged environment before things start going into the chart that cannot be pulled back, to say, hey, don't fix your operative note, even if it's imperfect. Don't document now what you were thinking about an hour ago now that the bad thing has happened. I will always deal better with notes that are imperfect than CYA notes. And frankly, plaintiff's counsel, those are giant red flags when there's an addendum, an addition. So this documentation component is one of the reasons for this meeting. The other, and it's notified through our Everbridge system, how you all get pages. So once it's put in motion, you get all the major players in on this phone call. And basically the documentation is key. And then also keeping people around sometimes to get into a discussion, to figure out what needs to be done next. And before someone goes home and is so upset that they're talking to their spouses and their friends and everyone else about what happened. It really is about getting that documentation, emotional support, and family support in place all at the same time. Then we get to the other part of this, and there's a lot of people that want to run to disclosure. And sometimes disclosure is absolutely important, and sometimes it's premature, and sometimes it's not appropriate. And what I would say is we have a disclosure of adverse events policy that's been in place for years. And I think one of the key issues is, you know, first of all, if you're going to I actually think these are out of order, so I'm going to start in a different way. The first issue is what happened? Let's figure out what happened. And did it change the ultimate outcome of the patient? And that's really the important issue is, number one, was it something that actually was wrong and something went wrong? And number two, did it change the outcome? And the best way I can put this is in the case of someone with I'm going to do it in an adult sense and then bring it to a ped sense. Someone with stage 4 cancer that was already hospitalized and has limited time to live. And there may have been a delay in getting blood or some sort of medication may have been delayed. this family is already going to be distressed, and the question becomes, does a disclosure help this family? Did it ultimately change the outcome of this patient? And oftentimes it turns out it didn't. So that would not meet the disclosure of adverse event policy. The goal is to be transparent with patients and families when it's appropriate to do so, but not to add to their angst, injury, questioning when actually nothing would have come out differently. So then let's talk about the disclosure. And that's where our risk management department really comes into play. And there's a couple of things. If you think the disclosure needs to happen, call the risk manager on call. Legal is often in the background on this, but the last thing any family or you wants are lawyers stepping into the room to meet a family or a patient, because that puts everybody's antenna up. People don't start listening, they start becoming defensive, and it really doesn't help. But we are often in the background assisting risk management in giving talking points or deciding who to disclose to, who should do the disclosing if there's a disclosure, and most important, the documentation of that disclosure. So one thing I can tell all of you is I'm sorry and I apologize are protected in the state of Ohio. It's not an admission of liability, and it goes an incredibly long way. If you have a family with a very difficult result, I have no problem with both the caregivers and the leaders interacting with this family, especially the caregivers that have known this family, and saying, we are so sorry this happened. But that's where it has to stop. That's not a disclosure. It is okay to say, we are so sorry this happened. We are looking into this. And you can say to the family, we will look into this. What Sarah and I usually tell people is, number one, have a point person in the group that's been dealing with the family. This may be the doctor, they know this best. It may be a leader. It depends sort of how this has gone down. And we often say, offer your card and your contact information to that individual. So there's one-to-one communication. That way you're not getting mixed messages. You're also not getting 2 or 3 people who may have a different opinion of what happened early on, saying different things to the family. Very important also, especially if the child is still in our care, to talk to our caregivers and say, do not speculate with this family. Residents get put in this position all the time, so I can't stress enough putting this down to the residents. And it's very easy for a resident to say, you know what, I'll have an attending come and talk to you about this today. So that you're putting the brakes on and speculating things. We many times, especially with young kids, have found that a surgical complication or something that really turned out way worse than we thought is a kid that has a disorder that we didn't know about yet and would not have known about in advance, which is why speculation is so important to avoid. Obviously, transparency is important because people can tell when you're bullshitting them, quite frankly. So what you can be transparent about, you should be. And that's what risk and legal is for. Use us as a crutch. If you want to say there can be true medical errors and true medication errors. Sometimes someone winds up in the PICU for a while and then they're back down. There's been errors with insulin more times than I can remember that has a brief instance of something happening, but ultimately the kid is okay. That's when transparency pays off. We recognize that we gave, long acting instead of short acting instead of long acting. Out of a precaution, we're going to put your child in the PICU. That bill will be written off, and that's what part of the communication that goes on in the background. Don't worry, you won't have expenses associated with this. The doctor will be here to check on you and if you have any questions. So sometimes these disclosures really take everyone's temperature down. And if there's reassurance that everything's going to be okay, that makes a huge difference. They're going to find out in the medical records, if they get a lawyer, that that's the mistake we made. So why not be transparent about it? But no transparency if we're just guessing. If it's, gosh, and I'm looking at this escalation policy, and the question about 60 minutes versus 180 minutes is a great example. Someone might speculate, gosh, if we had got that done in 60 minutes, the result may have been different. But you guys have data that actually, yes, there's a golden hour, but there's this window that actually meets compliance. Great reason why you don't speculate on things like that when you're talking to a family.
I wanted to pose a question.
Sure.
Chat. Do you have any advice for those of us who are frontline in challenging interactions with families in the ER or inpatient setting where a family member or parent may use threats of a lawsuit or asking to speak with someone in charge in order to try and sway decision-making? This most often occurs in situations where a child is recommended for discharge and the family is not in agreement. This is going to flow into the mental and behavioral health
Yep.
population that we're talking about. Do we automatically contact legal to make them aware, or is that not necessary? What would you recommend?
So great question. I would say that you'd be amazed how many parents like to threaten legal action because they think they know better than the doctor. So I don't think you need to call legal unless you think it's a behavioral health issue. I think, and Sarah will address that, then I would call legal. If you think this is a child that has been brought in for something that really was managed in the ED and they are appropriate for discharge, but mom, dad, foster parents, DCFS, anyone just doesn't want to deal with them anymore, and they're hoping that parking them at Rainbow will assist that, then I would engage legal. If this is just a family that's nervous, etc., deal with the caregivers there. And I know that it's busy and you can't always call someone in charge in to talk with the family. Document their concerns, because it's going to pay off if you've addressed all of these issues. Temperature came down with fluids, vomiting has stopped. I can give you any number of things that as a parent, you may think, I want a CT scan. That's the new thing that, gets requested all the time. Document the rationale for not doing those things. And if you can, make sure that you get someone in there to have a discussion with the family and document it as to why discharge is important. Don't be bullied into having a patient be admitted if they don't need to be admitted. If you're on the fence, then call that next person in, because maybe you will decide, this is actually, parents are worried about something justifiable. Maybe we'll do an observation, maybe we'll admit and figure things out. But there's a lot of threatening that goes on. The ED is such a hard environment. It takes forever. It's unpleasant. So that we see really often. And, we can be like at 767, the 8050 line, option 1. That is during business hours, that is a paralegal on call from my team. And they will escalate to an attorney within an hour, or you can use the attorney on call, which is 24/7. So you can always get in touch with the law department. A lot of you have my cell phone, and probably Sarah's too. And that's okay also. We don't mind. Rainbow is our friend. So that is another thing. And I'm looking at faces that have called me at any time of day, and that's perfectly fine. So when in doubt, escalate, but a lot of this doesn't need to be escalated automatically to legal. I hope that answered that. I saw a question over here.
A number of times been involved in disclosures that involve the bold and underlined. A number of times been involved in disclosures that involve the bold and underlined statement there. And, often with a family where a conversation goes very well, the obvious next question from them is, how and when will you communicate back to me what happened? And especially when it's an event happened, we know the event, we don't know why. They're not looking to press charges, but do want to, how are you going to prevent this from happening to the next kid? What's unclear to me is how much and when and if ever results of that sort of quality focused review can find its way back to the family. Because that's always their question to me, is when are you going to call me and explain how you're preventing this, what you've done?
And that's a great question. And I think the timing, you have to say, we go through an analysis process. We will be in touch with you when that is over. So then comes the second part that's a lot harder, obviously. And it can be, and that's where risk can help you absolutely craft that along with legal. It could be that you are going to say something like, oh, we now have a double identification system for this particular medication. We recognize that it didn't change the course of your son's treatment, but we wanted you to know that we put this in place. It could be that you recognize, we recognize that the white blood count was elevated at this sort of time. It was a decision as to if we would start antibiotics or not. We started antibiotics half an hour later. Ultimately, our review doesn't think that would have changed the outcome, but we wanted to let you know what we discovered. It can also be a conversation, which it more times than not isn't. Though this was a terrible outcome, actually, we met the standard of care. Do you have any particular questions? And be prepared for those. If it's something like, they're feeling, why didn't you do a study earlier? Why didn't we start antibiotics earlier? There's any number of those things that can happen. Why didn't you know that my child had this heart defect already? Those are ones that risk and legal can help you answer. Sadly, healthy kids come to us And we don't know about underlying problems because they've been seeing a pediatrician for years and there's nothing that triggered it to diagnose it. And we find out, a lot of times this child responded in this unexpected way because of A, B, and C, which we didn't know about. That's another thing that you can say. We discovered your child had a clotting disorder, a bleeding disorder, a congenital abnormality that was not screened for. And, that's another way to do that discussion. It's more art than science. And kind of my compass pointing north is what helps this family, especially in a really, really tragic outcome. Joyce.
I wonder, Nate, if your question is, how do you as the provider know that there is a mitigation strategy or change has been implemented based on the event? So I do think that's an opportunity for us. We don't always know that there's been disclosure. We know if there's disclosure for a very serious event, but not the less serious events, maybe a medication error, things like that, that didn't result in serious harm. So I do think we have opportunities to figure
And from
out.
the adult floor, we hear that all the time, by the way, is how do we get this back to
Yes.
our caregivers that were involved in it? So that's a really good point that we don't see from the law department. We try to do lessons learned, but sadly the lessons learned are when there was a really tragic outcome. Sometimes it's better to learn from the ones where there wasn't a tragic outcome to prevent it in the future. So that's a really good point in learning opportunities, Joyce. And, the obvious, but I think everyone in this room knows this, is we know there are staffing issues. We know our EDs are busted and overflowing and, there's only so quick we can get to people. That's never what any patient or family wants to hear. So that's not part of the disclosure. Yes, John?
You're being reported a lot of families.
It's 100% true. I do want to tell you, there is a policy. If someone puts out a recorder and you don't want to be recorded, and I've said this to many of our physicians, and I will stand by it. I've yelled at lawyers on the phone. I have no problem. If they're being obvious and not having something in their pocket, you can say, listen, I want to talk to you, but I don't wish to be recorded. If they say, no, I'm recording you, you can step off. You can step off that discussion and the care. Obviously, if a child needs care, you continue to care for the child, but you do not need to be recorded. But you are right. Every phone call you get, every meeting, you can assume that someone basically is wearing a wire. Ohio is a single knowledge recording state. So only one person, meaning the recorder, needs to know that they're recording you. So it does become admissible. And, sometimes it's for the best reason. You have one family member at the appointment and you want all of these family members. I still have advised physicians, especially John, you're a great example. There may be lots of family involved in a baby that's been in the NICU for a long time. I would say, you know what, they can call me. I would never have something recorded to play back to a family later if it can be avoided. Or we could have a meeting if you want them to come in. We'll schedule a time to meet with grandma, sibling, whatever. But you're right. And thank you. John, I think you've become very aware of that. But it's true. In this environment, virtually everything can be recorded. Not only that, with AI. So it's actually a transcript, which is even somewhat worse sometimes. So documentation do's and don'ts, I do think are important when there's a safety concern. And what I can tell you from a quality protection and legal protection standpoint, if you have the minimal amounts in the chart to identify that an event has occurred, then every communication you have with Midas in writing, with me, my team, with the risk team becomes privileged and we can protect it. You can scream about whoever didn't answer their call for 2.5 hours, the fact that there wasn't enough staffing at that moment on the floor, the fact that something was coded wrong, in the chart, so we didn't follow the right protocol. You can do all of that in Midas or talking to one of us, but in the chart, it could simply be, let's say a child was dropped. I'm making it as easy as I can possibly make it. During a delivery, happens. Okay, child's being delivered. So you're going to say child was delivered at such and such a time, was either eased to the floor or fell on the floor. Radiology was called, orthopedics was called, done. All the rest of the stuff that may have led to that is for somewhere else, because then it's not discoverable. If you don't document that event, it could all become discoverable. So it really is document that quickly, with the minimal information involved in the patient chart to identify that an event occurred. Then that attorney, when they get the case, can't get all sort of the back data, the metadata, all of that stuff, because it's privileged. Think and choose your words carefully and state facts objectively and truthfully. I have had many cases where someone is not answering the phone in the middle of the night, and the person making the call wants to document for themselves, which I understand, that they went up the chain of command and nothing was happening. It is very easy to say, page Dr. X, 10:20 p.m., page Dr. X, 11 p.m., page Dr. X, 11:20 p.m. That's showing someone that is making that effort without throwing that under the bus and giving opinions. Because then at your deposition, it's going to be, oh, you said Dr. X never answered his calls. Why didn't you call Dr. Y if you know that's true? So really, objective is so important. And I do understand frustration. Sometimes we can deal with frustration if it's objectively documented. When it's subjectively documented, your deposition is not going to be fun, and they're going to turn it on its head. They're going to say, if you know this, and if this is true, what did you do to prevent this? So it never works out the way someone hopes it works out. And Sarah and I hate preparing people for those depositions, because it's, okay, let me give you the first question that a really skilled plaintiff's attorney is going to ask you. Like I was talking about here, if anything comes up that you are doing something differently, especially from an EPIC tagged process event, someone that you're going to let, example in OB, you're going to let labor longer than what the guidelines say because you've done certain assessments, and you're just going to say, I'm going to let this go on 10 minutes longer. Same thing with a kid. If you see a kid trending in a different direction, but they're not quite there yet, and either flags are coming up or something in your process is coming up as to why you may not do this for a bit longer, document that objectively and simply, and we can always defend it. If your thought process isn't documented, you can talk about it in a deposition, but it doesn't hold as much weight because it's after the fact. It's Monday morning quarterbacking, where if you're doing it at the time, we're human and we make not even mistakes. We make judgments that through the retroscope may not have been correct, but actually at the time are very defensible. So really pristine documentation does matter. Okay, so I have been in more patient charts than my own and my children's than I can count. No, if you spoke to legal, if you spoke to risk, nowhere should that go in the patient chart. I am in many, many patient charts. It's lovely. I've been, all kinds of things, but it happened last week. I literally get something to us later and you see the documentation, spoke to risk, spoke to so-and-so in legal. No, that takes and what you need to understand is it's sort of, they call it fruit of the poisonous tree in law. And it's sort of like, if it's on there and you did it, then the whole tree becomes poisoned. So then those communications with legal may not be privileged because you broke that privilege. The same thing goes for emails. And we are all so guilty of this. You said something bad happens, you want to get all of the right people involved in the email. And either you leave the lawyer off the first email, which happens all the time, and or you include way too many people in the email that also includes the lawyer and may not have been crafted in a way that was seeking legal advice. So every communication with an attorney is not privileged. Hey, Lynn, did you have a fun vacation? That's not privileged. However, if you're seeking legal advice, it may be privileged. So the instinct to put everyone on the first email when you want to get people together, think about who's in quality, who was involved in that care, who's in risk, and who's in legal. That will get things. So Ethan is safe. Dr. Macias is safe. Joyce is safe. There's certain safe people that will get this escalated. Whoever was the most senior person in that department on duty at that time, all of that, plus the lawyer, will stay privileged. When we start having, and I've seen emails that go basically everywhere, it can't put the toothpaste back in the tube. So really important that to think about communications you're putting in writing and how you're putting them in writing and who you're putting them in writing to. Phone calls are great because they are not discoverable to the extent that you get to answer. I called my lawyer, and that's when the deposition ends on that topic. And if it doesn't end on, well, what did you say to your lawyer? You're a nice lawyer that's sitting there. We'll object. We'll call the judge, and the judge will absolutely say, yep, that's privileged. We can't go there any longer. Once there's an email and it's like, well, why is this person on this email? And what did they have to do with anything? That's where it gets a lot dicier. Also, and this is something that's kind of counterintuitive, where I talked about saying, put the minimum amount of the event in the chart for documentation. Do not add to the documentation that there's a past report. That will all get discovered in the back because everybody will talk to you. Hey, did someone do a past report? Our risk managers can look in 10 different ways and see if anyone's had a past report in with regard to that patient or that event. But don't put that in the chart. That's another issue that we've seen plaintiffs' attorneys say, well, wait a minute. If they thought it necessary to document that in the chart, maybe this isn't privileged anymore. And unfortunately, Ohio courts are really, really trying to disassemble the quality assurance privilege. Not so much attorney-client because judges are lawyers, so that is more protected. But anything that might breach that QA privilege and like certain things that get presented to a different audience. So some of the data that came up today arguably is maybe privileged, maybe not. Sarah and I are here. They make arguments about that's not privileged because you gave it out to this many people, or you give it to our CFO for budget reasons. Maybe not. So that's why it's really important to make your universe small initially, and then the right people can be called in as is necessary. Okay, so I did a couple of scenarios. One, ironically, which I got as an event this week. So that was kind of interesting to do it. And I'm going to ask you by a raise of hands, do we disclose or do we not disclose? And then who would do the disclosure in your thought process? So this is event number one. A parent of a pediatric patient calls the nurse on call line after hours, advises that her 3-year-old son has a fever of 102.9, is fussy and unable to sleep. The pediatric nurse on call looks through the protocol and asks the appropriate questions for the path they have followed. The nurse learns that the child has been eating and drinking and is not yet night potty trained and has a wet pull-up. Advises the parent that they can alternate Tylenol and Advil to control the fever and should call in the AM for a same-day appointment with their pediatrician. She does not pass the call to the pediatrician on call pursuant to the protocol she followed, and does not advise mom that should certain symptoms change, that this would merit a call to a return call to them or a visit to the ED. We can presume that that should have been something that was said regardless, even if it didn't meet the criteria of phoning the pediatrician in the middle of the night. Remember, all these calls are recorded. The parent calls the office the next day and advises the office that the child's fever is still 101, even on the alternation protocol, and the child is now very lethargic and difficult to engage. The parent brings the child in immediately for a very first morning appointment, and meningitis is suspected. He's transferred to the ED via ambulance, and throughout the day, viral meningitis is diagnosed. The child is in the ICU at Rainbow receiving supportive care. He appears to have some brain edema that has caused some neurological deficits. It is then determined that it was determined that the correct protocol path was not followed by the nurse overnight. She made some choices that led her to the wrong decision, and the parent should have been directed to call back immediately if fever was not controlled or there was a change in the child's mental status. It is likely that the pediatrician would have sent the child ED. The ED referral would have happened about 6 hours earlier. Remember what I said about disclosure? Does this require a disclosure? Yes, raise your hands. Okay. No, raise your hand. Okay, now I'm the lawyer, so I'm not the clinician, but this was viral meningitis. So tell me what would have been done differently for this child had anything happened earlier. There's not really another good option. So do I think that there's opportunities for better care here? 110%. Should the nurse's actions been reviewed? 110% to figure out why did she go down that wrong path that shows up on the computer? But do I think that there's a disclosure that's necessary here because the outcome would not have been different and the course of treatment would not have been different? No. So there's one example. You can argue both ways, but when you're having these kind of discussions in a situation like this, it's a good one to think about. Is this really ripe for a disclosure? We may still get a lawsuit, and there may be some somewhat indefensible issues of, well, if we gave supportive care earlier, we might have avoided some of this, but that's stuff we can defend. What we can't defend is a disclosure saying, yes, if we had seen this child 6 hours earlier, we are certain the outcome would have been different.
How do you think differently about a proactive disclosure in a situation like, hey, just so you know, we screwed up on the front end, but it didn't change anything, as opposed to what seems very likely in the circumstance where the family would be asking you, shouldn't they have brought this kid in overnight, and then acknowledging that would have been the right decision decision, but it would not have changed anything in terms of what.
And I would still say, don't do that yet. I would still say, we recognize your concerns and we always look into cases like this, only because let's say that when you are in a group of clinicians, which I am not, you truly decide that it wouldn't have made a difference. I would rather have the disclosure take place when you have that answer and you are comfortable with it than sort of, yeah, we recognize the wrong path was followed. Maybe, and maybe not. You know, we'd look back and say, what really did happen? I think that the real flaw in this is if something changes, don't call, which should, I mean, call back, which should have been a part of everything. And maybe the fact that it didn't get to the meningitis pathway isn't so important as, hey, nurse, you need more training on when you tell someone to call back. If this had been a delay of 12, 24 hours, I might even feel differently, but 6, I'm much more comfortable with not the proactive on this one, because we might wind up in the same boat.
Yeah, I have a question. Do I need to use the mic? Can you hear me? Oh, sorry.
Hi, I'm Richard Martin. My question relates to guidelines versus protocol, okay? I attend on the neonatal intensive care beds, which are the step-down beds. And every day we send 2 babies home who are premature. And we have guidelines. You should be on oral feeds for 48 hours. The NG should be out. The baby shouldn't have had a recent episode of desaturation. And my nightmare scenario is that I get a call the next day that the baby died at home. It hasn't happened, but Jeopardy said that these are guidelines we have.
Yeah.
Do I make sense?
Oh, Dr. Martin, you make
What
perfect
is
sense.
the vulnerability here?
So guidelines are always better than policies and protocols because they are just that. They are guidelines. However, I can absolutely say that a plaintiff's attorney is going to put up on a board like this, oh, look at the guidelines, and these things didn't happen. Best practices is follow our guidelines or document why we didn't. And that's why I talk about that documentation of, you know, are parents pushing you to bring the child home? Are they have they had premature babies before? Are they well educated on that? There may be some reason that you're sending this child home without meeting all those milestones. That should be documented. But if it delays the discharge, do it. I mean, I can't say enough that is the nightmare. The bad thing happens, and the first exhibit that the plaintiff's attorney will put up is, why didn't you follow these? The answer is always, these are guidelines. We look at the patient as a whole. 100% like it better. Guideline is a much better word from a lawyer's standpoint, for sure. But like I said, follow the guidelines. It's our best. Yes.
Thanks for doing this then.
Oh, no problem.
First disclaimer, I hate phone medicine with a burning passion. It's so hard. I think most of us, if you had taken the first poll of should the kid been sent in at the first phone call, most of us would have voted no. And the fault here was failing to imagine every possibility down the road. How do you guys as lawyers deal with the, well, of course you should have called back if something changed about your kid?
And so that's why I think the nursing in this particular environment where we have a nurse on call line, I think the training is imperative that's the end of that phone call. Like that is, I think, imperative training. You can't catastrophize with what you guys do with living if you did. I mean, and I'm the biggest hypochondriac in the world.
Yes, I do coach trainees and always end with, but if you have concerns, if something changes, and try not to then create every if then scenario. And I'm afraid then it sounds like blaming the victim, but where do we share the responsibility?
Well, and we have done, I
with
mean,
families?
sadly, we have had cases like that quite often. We've had cases here recently like that. You never want, the parent guilt is overwhelming when you made a judgment call in the moment. It could be your kid finally seemed comfortable and went back to sleep. And we all get that, especially with young kids. It could be that you're like, this is your 4th kid. You've seen this a million times. I'll just get him to the pediatrician in the morning. That's the soft sell we can do if we have to defend a lawsuit. I mean, I would never want to be in a parent's space when they are going through all of this tremendous what ifs and guilts. But it is something that we become very aware of very quickly when we talk to you and either someone has come to us presenting a claim pre-suit. And that's a discussion. I can give you an example. That's a discussion with their attorney, not with them. You know, the attorney may call me and say, oh my God, I have this slam dunk suit. You let this kid go. They died at home 8 hours later. And you actually know that admission was recommended and the parent turned it down. or you know that they were told, absolutely, if this or this changes, please bring them back. We've had a case where we discovered there was co-sleeping with kids with huge respiratory problems. I mean, there's always these horrible moments where you realize there's some parental or patient fault. It does no good to the family to bring it up then. We'll bring it up later if there is a lawsuit. But I am a huge fan when there's good documentation of patients and their families have their own responsibilities too. It's that there's an art to using that to defend a case, and certainly not to get in someone who, you can internalize this, who's looking for someone other than themselves to blame. And so I think really important to know it's there, it's 100%. That's why it's good to have those sort of boilerplate statements, which is if something changes with your child or you have a level of concern, please call back. And I can tell you from our nurse on call systems, when they get the second call, they almost always say go in. So they are trained well to know that. And if we see gaps in that, we will make sure they get retrained. And I think that's the best answer I can give you to that horrible question, because it is an awful set of circumstances. Okay, got another one. So 12-year-old patient presents to the Rainbow ED on 7/6/24 with a history of vomiting, diarrhea, and diffuse abdominal pain for the last 12 hours. Examination shows diffuse pain, no rebound tenderness, and no rigidity. Blood work is taken and fluids are administered. Blood work shows dehydration and a white count of 20,000. Over the time period in the ED, the vomiting ceases, fluids have normalized, his markers for dehydration, and he has some slight pain, but he's much better. There has been no vomiting. He's eaten a few popsicles. He's diagnosed with viral gastroenteritis and sent home to recover. About 24 hours later, he returns to the ED with significant right-sided abdominal pain. Blood work is repeated. White blood count is now 23. A CT diagnoses acute appendicitis, and he's sent for an immediate appendectomy. He did not perforate prior to surgery. His recovery is uneventful, and he is discharged the same day. Review of the care indicated that his first ED visit met criteria for a CT to rule out appendicitis, or at least an ultrasound if you don't want to do CTs, and that the standard of care was not met. With these facts, raise your hands yes for a disclosure. And I like what you do for, it's very interesting to see who picked yes. Raise your hand no for a disclosure. Okay, so the lawyer votes no because the outcome was the same. He didn't perf, he didn't become septic, he had an appendectomy, he had a normal recovery. What we would do is write off quietly in the background that first ED visit. The patient should not be charged for it. Ultimately, he was not going to be managed medically. He was going to have an appendectomy. He had the appendectomy timely, and he had a good recovery. Had recovery not been good, that's a disclosure. But that's the example of what we do in the background. When you notified us, we would quietly make sure they were not billed for that first visit. We know there might be a lawsuit, but once again, lawyers love money. It's really the main fact here. Lawyers love money. And the bottom line is if there's no long-term damages, they have no interest in talking to you because their fees are contingent on how much money they can get. And in this instance, these are what are called lower caps cases. If there was anything, it's about $250,000. And basically with no real damages, I'm not sure that it even meets the criteria of that amount of money. So what you can usually do to not have the family be up in arms is not have them see a bill from that ED visit the day before. If they go to a lawyer, the first thing the lawyer will say is, what were your bills? And they'll be like, oh, we didn't get billed for that first ED visit. And most good plaintiffs' attorneys, and most of the ones that deal with kid cases are pretty good. Their antenna will go off and they'll say, they also have 19 years. So if something should happen with this child having horrible scar tissue, something that happens later, they have a long opportunity. Well, not 19 years. In this case, he was a little younger, but they have time to do these things. So I would err on the side of no disclosure here because there's wiggle room and there was a good outcome. But that's the difference between a doctor and a lawyer. Yes. No, because we don't send a letter with it. So what we can say is, listen, when we see a bounce back ED visit within 24 hours, it's our patient satisfaction policy, service recovery, and these wonderful words we can use that we typically don't bill to alleviate the patient's financial burden for having had a surgery the next day. Yes.
Yeah, I agree with you that the outcomes, and I would actually tell the parent that, like, because for two reasons. One, actually one of the main reasons I would tell them that, because I wouldn't want the parents to feel guilty that they
Understood.
And that, it's okay to tell them that, hey, but my opinion, they wouldn't have made a difference. It's okay to tell them.
Yeah, if you feel, like I said, oh, so the question was, in the first scenario, if you wanted to say to the family, listen, I don't think the outcome would have been different if you had called back or brought him in earlier. The question was, is that okay? So what I will say is I would gauge the family very much in making a statement like that. But to your point, if you have a guilty family who's realizing, oh my God, why didn't I bring him in earlier? And this is a discussion, not a formalized disclosure, but a discussion with the parents. My God, if I had brought him in the middle of the night, I thought about it and I didn't, would that have made a difference? That's different than a disclosure, though I would document that you said that to the family. That's not a formal disclosure. That's saying parent asked if bringing the child in earlier would have made after the phone call would have made a difference. I responded, one line, but I get it. And that's not really a formal disclosure. That's a response to a parental question. And it just requires artful documentation. Yes, John?
The first case was neurologic injury.
Yes.
So the potential damages are much higher.
Yep.
And now you'll always find somewhere out in the country to say, oh, it would have made a difference in this kid's brain status, at least, that.
But you're right. I guess as long as you can stand by the statement, like I said, if you can really stand by that statement, it's not my favorite. Like we made a decision not to disclose in that case. And hopefully you would have escalated it and it would have been a group of clinicians making a decision that would not have been the case. But then you can talk about, hey, this family's asking questions. It can be an interaction. Should we tell them this? And we can talk about it. It's going to depend on the family dynamic. It's going to depend on the nature and extent of the kid's injuries. Have they acted litigious? All of those things come to mind. But it's the in the moment that I wanted to talk about there is like, does this meet the disclosure of adverse event policy and what should we do? But I guess if you're a provider that's having a long relationship potentially with the family and they're asking questions, I'd say talk to risk. Actually before you answer it, or if you do answer it in the moment, know that you're going to stand by that answer and make sure that that conversation is documented in the chart. I don't know if I have another one or not. I can't remember. So I will go forward and see. I have one more, and this was the one that came to me this week. So it's kind of interesting. 14-year-old male with no significant medical history presented to the UH Ahuja ED for severe right lower quadrant abdominal pain. Was seen by the APP and attending. A CT of the abdomen and pelvis showed a normal appendix. The patient's pain improved with analgesic meds in the ED, and he was discharged home with a diagnosis of lower abdominal pain. This really did come through, guys. 2 days later, patient presented the UH Rainbow ED for right testicular pain. Ooh, it localized and swelling. Ultrasound revealed a right testicular torsion, and a right orchiectomy was completed by urology after the testicle was identified as non-viable. Review indicates that with a negative CT and the age of the patient and nature of the symptoms, an ultrasound should have been performed at the first visit. I think that is right, by the way. Should there be a disclosure in this case? Raise your hands for yes. And raise your hands for no. So I believe this one requires a disclosure. May have had the same result by then, but at least if we had done it then and determined it was non-viable, we met the standard of care. By having 48 hours there without that even in the process of our diagnostic thought, I think that we do require a disclosure because we can't know if it was viable 2 days earlier.
You can rein me in if this is going off the rails, but the piece of information I don't see in there is whether they actually did an exam under the underwear at the time.
And that's because I don't know the answer to that, because it came up as and that's a really good question, because if it was swollen, that is a really big problem.
So it's not
Let's
about the
assume-
imaging, and here's where I might go off the rails. The huge push towards we can't possibly as doctors look under anyone's underwear without 3 licensed chaperones.
Well, it's one. It's one. Thank you very much. And they're not licensed.
Wait.
They're just around.
Like,
But
how do we reverse?
okay,
this
so first of all, this
trend?
was
That's
an
not
ED
purposeful.
visit. This was an ED
Yeah.
visit. So what I would say, in a boy this age especially, I know that abdominal pain can often be a testicular
I remember as a
torsion.
senior resident going in with an intern who couldn't figure out the abdominal pain and pulling down the diaper and said, how about that incarcerated hernia? What do you think?
There
of
you
that?"
go.
Like, It's.
So we have a
what
great
unacceptable
chaperone
is
policy
and
that is,
teaching people that that's a special thing that needs informed consent, then
well,
it's a
first of all,
physical
this is a 14-year-old who is likely there with their parents, so I can make that
Yeah.
easier with the chaperone. I would say that that is one of the gaps in this is number one, there was no clinical exam of the groin, and secondarily, no imaging. So that's why I feel like this one is a catch, and that's teaching. That's, hey, male patient, teens, not appendicitis, not a hernia that you can see. What are the other things possible? So I think there was a miss in two
And
ways
we
there.
as a society need to reverse this trend that that's anything other than part of it.
The nice thing in peds is a good percentage of the time, mom or dad is there because they provide the consent. Gets dicier if you have someone, a young child come in for some of the things that they want to talk to you about privately. Always get a chaperone in the room. I respect that sometimes it can't be mom or dad for very good reasons that are covered under exceptions in Ohio. But the chaperone in those instances, especially because you may find it was a result of trauma or something that they didn't want to do consensually. So that's it for me. Gonna have Sarah
Thank you,
come up.
everyone, for the excellent questions and discussion. In the interest of time, we'll need to move forward. But Lynn, I'm going to hand the computer to you. If you
Okay.
could just answer a couple questions in the chat, I would appreciate it.
Did I answer these just in the chat? Can I just type them?
Oh, my fancy here. Because the chat is up, I don't think I can advance
the
here.
chat's up.
Can we? There we go. There we go. So I know there's only about 5 minutes left. I will just kind of speed through the presentation here this morning on navigating the challenging discharges here at Rainbow. And they are not only at Rainbow, they are across the system. They are in our EDs, our community hospitals, and they are both, pertinent to you in the pediatric setting, but we're seeing the same thing with the elderly and some of other settings. It's stuck again because of the chat there. Yep.
Every time we try to answer the chat, it pulls it back up on the screen. So just for those on Zoom, we will answer right at the end. If you hang on a couple minutes, thanks.
Great. Okay. So as many of you in the room know, Rainbow faces the growing challenge of managing pediatric behavioral patients with no immediate mental health or medical needs. We see these termed in the medical records, and when we talk about them in the community, as social admissions, boarders, or patients awaiting community placement. And these are minors with no acute medical or psychiatric needs. That doesn't mean they don't have needs. That means they usually have behavioral needs or complex medical needs that need to be cared for in the community. These are often people with no family options. Their families are either fatigued from taking care of them, or there just isn't anyone left. There's no one in their family who wants to take care of them. They're also people who have, no foster care options, facility options, or residential placement options. And ultimately, that leaves us with no safe discharge plan, usually from the ED, but we also know that Rainbow 6 has been hit hard with this over the last few years as well. So this population poses unique risks and liabilities. It impacts the safety of the patient themselves, also other patients on our floors or in our EDs, and certainly our providers, our nurses, our physicians, and other staff who are caring for these individuals, both in the ED and on the inpatient floors. And finally, it impacts the environment and strains our resources. It takes away from caring for other patients. It is, dollars to our hospital and so forth. So the goal here in the next few minutes is just to learn how the clinical providers, the social work team, and legal can all partner together to try and find, a good outcome for the patient and for our system. One thing I want to emphasize here is that Lynn and I are always available to get involved in these situations. It's important to involve us early. We had one not out of Rainbow, but from one of our community EDs about a month and a half ago that the patient had already been in the ED for 7 days before we were contacted. That's a tough one. Our ED here at Rainbow has been very good about involving us usually within the first 24 to 48 hours. So that's the thing to do.
I want to stress that this is a nationwide crisis. It is not unique to Rainbow, Northeast Ohio, or even Ohio. It is happening across the nation, and it is a trickle-down effect from the lack of foster care and crisis placements for these kids. There is just an absence of foster cares, group homes, residential settings. COVID has impacted that. There's been a deinstitutionalization of foster care. There's been underfunding of foster care. So all these things that are happening in the community are resulting in more and more patients coming into Rainbow, inappropriately. And at the same time that more patients are coming, they're coming because there is a greater need. We're seeing high numbers of behavioral and mental health patients across the nation with a lack of beds. And here you can see what happens as a result of all these factors coming together across the nation. Hospitals are considering this dumping. There are patients presenting who shouldn't be presenting to the ED, but that's usually because there's just kind of nowhere else for them to go. So here's the estimated incidence at UH. Now, I think these numbers are probably low, because these are just ones where the law department has been called over the past few years and that we have gotten involved in. Certainly the ED providers are handling many of them on their own now because they kind of know the triage and what to do. So again, these are low. And I know we've started out the new year with a bang because I was involved in discharging a patient with the ED just yesterday. And Dr. Macias has put a note to me in my email that there's another patient to deal with today. We often see an increase around the holidays, so that's kind of not surprising coming out of the holiday season. Let me see. So what is our strategy? Well, number one, it depends on how the patient got to us. If the patient came into the ED, the first question I ask is, is the medical screening exam done? Is the patient clear from a medical and psychological perspective by our physicians? If the answer is yes, and they do not have, any type of complex needs, meaning they don't use CPAP, BiPAP, or, have a tracheostomy, they are just the typical behavioral admission, I say, don't admit that patient. The reason being is if you admit them up to say Rainbow 6 and they don't have a medical or psychological reason, it becomes extremely difficult to get that patient out. Our judges, our children's services, community partners all say, well, that patient is safe and tucked into a bed, so we can drag our feet on getting involved. Certainly with the patient with the complex medical needs, even though they should be cared for, say, out in the community or at a facility, sometimes those patients do have to be admitted just because you can't have a patient on a ventilator in the ED for 7 or 14 days. The next question is, how did the patient, or after we determine how the patient presented, it's what's the situation in terms of custody? Is there a parent involved? Is Children's Services the legal guardian of the parent? And we kind of got to work through those issues. If there is a parent or guardian involved and they've presented to the ED, we want to make sure that we try and get that person to stay. So we try and get them to acknowledge that they need to stay and work through this care with us. If the patient presents by ED or by police, which we see so frequently happening, we at minimum want to get the police's information. So, what district did they come from, who the police officer is, and so forth. Get as much information, try and get them to stay, but usually they head out the door. When we talk about custody, if the parent or guardian has custody, again, they may be saying, well, I do have it, but I don't want it anymore. And that's our most difficult situation, where a parent truly legally has custody and leaves and won't come and interact with that child anymore or pick up that child. In those situations, we will continue to try and call them, make contact with them, and emphasize the need for them to come back. We can tell them, we are going to have to inform the county services, so DCFS, and then we do so. We make the referral to DCFS. That can be right through the 696 Kids hotline. And then our social workers are very good with having individual contact with caseworkers and escalating up through the county services, so to the supervisor and up to the head of DCFS if we need to. We need detailed documentation of each and every time that we try and reach out to the parents or guardians or to county. County in particular likes to talk to people on the phone, to our providers and to our social workers. That's fine, but afterwards, our provider needs to sit down and write a note because we want to create a good record that we have reached out to the county or to the family many, many times trying to get them to come and take this child. As a final option, we can file a complaint and neglect. That is our legal option. And I just put one up here so you could get the sense of what we are looking at when we file these with the court. They are filed with the juvenile court in the county in which the child is a resident, or as a default, we could file them in Cuyahoga County because Rainbow is here. But what we are saying is that they are abandoned, neglected, and dependent. The relief we're looking for is right here, which is essentially getting an order from the juvenile judge to say, parent, come pick up this kid, or county, come pick up this kid, or county, take custody and come pick up this kid. And this is the important part for our providers. We'll be leaning on usually the attending physician and the social worker who are dealing with the issue and setting up affidavits that then they execute and we submit to the court because they become our medical evidence. And we basically just say that they know this child has been evaluated, this child is medically and psychologically clear, has no inpatient needs, and the child needs to be taken from the hospital. And you can see how we kind of go through and detail that. And I'm happy to answer any questions, afterwards, or if you want to reach out to me, you have my cell and my email. And again, just get us involved early if there's any issues.
Thank you so much to Sarah and Lynn for the excellent presentation. I know whenever we have our wonderful legal team here, we have a lot of questions and discussion and could go on for another hour, but unfortunately we're out of time. We just had a few wrap-up things here, which we've already touched on, the importance of guidelines, knowing that this is coming to our DWP and to policy stat, having all of that in one place. And then with curbside coming, being able to really take those clinical practice guidelines and use those innovations to improve our care. So a few takeaway points here on the proactive safety tools that we discussed, the importance of using huddles, especially around sepsis. As Lynn spoke about the rapid escalation of high-risk events and using the disclosure tips and documentation do's and don'ts, and understanding that our clinical decision support tools will enhance the opportunities for us to work smarter, not harder in the future. So thank you all again. And there is a code here for the CME credit. And one last reminder, if you're in person, sign in. If on Zoom, make sure that you have your name up so we can submit credit to MedIQ for the CRME. And thank you again to all the presenters and participants for joining.